Dr. Berkeley, thank you for joining.
Hello there. Can you see me?
I'm just checking as we speak. For the moment, I don't.
Okay, let me see if I can figure out why.
I just have
Okay, I see. Matter. Okay, good. Now you should be able to see me.
Indeed. Thank you so much.
Very good.
So that concludes our tests for today's virtual press conference. So please stand by. We are most likely running a few minutes behind schedule, but hopefully not very many. Thank you to our guests who have joined. Thank you to our interpreters here in the room. And of course, thank you to all our journalists who are joining us online. Please stand by.
think I have.
Hello, everybody. This is Fadila Shaib speaking to you from the Geneva WHO headquarters and welcoming you to our global COVID-19 press conference, a joint one today with Gavi Alliance and CEPI, the Coalition for Epidemic Preparedness Innovation, today, September 21st. Before we start, I would like to explain why we are not wearing masks. We have set up this room so that we are all physically distancing in accordance with WHO guidance. The room is a large one with limited number of people in it. This being said, the subject today is COVID-19 update with a focus on equitable access to future vaccines, therapeutics, and diagnostics. So please get your question ready on this important and interesting subject. As always, Dr. Tedros, our Director General, will address you first. And joining Dr. Tedros to answer your question, we have several WHO experts, Dr. Mike Ryan, Dr. Maria von Kerkhoff, Dr. Maria Angela Simao, Dr. Soumya Swaminathan, Dr. Bruce Aylward, and Dr. Catherine O'Brien. And joining us remotely are the two principals from Gavi and CEPI, Dr. Seth Berkley and Dr. Richard Hatchett. The briefing is being translated simultaneously into the 6 official UN languages, plus Portuguese and Hindi. Exceptionally today, no Chinese translation. We are sorry for that. Now, without further ado, I will hand over to Dr. Tedros. Dr. Tedros, you have the floor.
Shukran jazilan, Fadila. What Fadila said is true. And when necessary, we use masks, and it's always in our pockets or bags. On the right side, the mask, on the left, the sanitizer. So we have to always be very, very careful. And then, of course, the distancing too. Good morning, good afternoon, and good evening. Today marks the 75th anniversary celebrations of the founding of the United Nations. 75 years ago, the nations of the world came together in the aftermath of the Second World War to resolve that the only alternative to the horrors of international conflict was international cooperation. Perhaps no crisis since the Second World War has demonstrated more clearly why we need the UN than the COVID-19 pandemic. We can only confront this common threat with a common approach. WHO is proud to be part of the UN family. As the nations of the world meet virtually for the UN General Assembly this week, WHO has 3 key messages. First, the pandemic must motivate us to redouble our efforts to achieve the Sustainable Development Goals, not become an excuse for missing them. Second, we must prepare for the next pandemic now. And third, we must move heaven and earth to ensure equitable access to diagnostics, therapeutics, and vaccines. We continue to call on all countries to use every tool at their disposal to suppress transmission and save lives until and after we have a vaccine. From the beginning of this crisis, WHO has championed and supported the global effort to develop a vaccine. We have developed target product profiles, criteria for the prioritization of vaccines, and a core vaccine trial protocol. We have engaged with vaccine developers and academics to standardize lab assays, animal models, and other normative methodologies. We're also helping to match manufacturers with trial sites. In April, WHO, the European Commission, and many partners established the Access to COVID-19 Tools Accelerator to speed up the development and manufacturing of vaccines, diagnostics, and therapeutics, and to ensure fair and equitable access for all countries. Together with Gavi and the Coalition for Epidemic Preparedness Innovations, CEPI, we also established the COVAX facility, which will give participating countries access to the world's largest and most diverse portfolio of vaccine candidates. The overarching goal of the COVAX facility is to ensure that all countries have access to vaccines at the same time, and that priority is given to those most at risk, including health workers, older people, and others at the highest risk. We have no guarantee that any single vaccine now in development will work. The more candidates we test, the higher the chance we will have a safe and efficacious vaccine. Almost 200 vaccines for COVID-19 are currently in clinical and preclinical testing. The history of vaccine development tells us that some will fail and some will succeed. The COVAX facility enables governments to spread the risk of vaccine development and ensure their populations can have early access to effective vaccines. Even more importantly, the COVAX facility is the mechanism that will enable a globally coordinated rollout for the greatest possible impact. The COVAX facility will help to bring the pandemic under control, save lives, accelerate the economic recovery, and ensure that the race for vaccines is a collaboration, not a contest. This is not charity. It's in every country's best interest. We sink or we swim together. The fastest route to ending the pandemic and accelerating the global economic recovery is to ensure some people are vaccinated in all countries, not all people in some countries. Recent opinion polls show the overwhelming majority of people support equitable access to vaccines. Our aim is to have 2 billion doses of vaccine available by the end of 2021. We're encouraged to see a large number of countries signing up to the COVAX facility, but we face some daunting challenges. For the ACT Accelerator to work as planned, it must
and delivery and rollout of vaccines, which is obviously critical to making them work. Thanks for listening. Back over to you, Dr. Tedros.
Thank you so much, Seth. And that's very, very clear. Now I ask Fadila to proceed with the rest of the today's session. Thank you, Fadila.
Thank you, Dr. Tedros. Thank you, Dr. Berkeley. We will now open the floor to questions, but before that, we will ask the CEO of CEPI, Dr. Richard Hatchett, to give us his opening remark. Dr. Hatchett, you have the floor.
Thank you very much. I would like to thank first the countries who have formalized their commitments to the COVAX facility. I also want to thank my friends, Dr. Tedros and Dr. Berkeley, for their opening remarks. And finally, I would like to thank all my colleagues at WHO, at Gavi, and CEPI who have worked tirelessly for months to help bring the COVAX facility into existence. Months ago, we foresaw the risk that the scramble for vaccine would result in the same kind of misallocation of vaccine that we observed in the last pandemic in 2009. CEPI, as an organization, invested early and in 9 vaccines, creating the largest global portfolio of COVID-19 vaccines in the world. Today is an important milestone on the way to the development of a globally fair allocation system. It is a product of the scientific community, of rich and poor countries, and global NGOs coming together to face a common threat. CEPI and Gavi and WHO are wholly committed to ensuring equitable access to COVID-19 vaccines. COVID-19 cannot be beaten one country at a time. We must be able to share life-saving vaccines globally at the same time. Humankind has never done this before with any new life-saving medical technology or intervention. We are on our way to setting a very important precedent for the world. What we are seeing today in the announcement of the countries that have formally committed to join the COVAX facility is hugely encouraging. A genuine global commitment to respond to a pandemic threat through collective action. There is indeed a very long way still to go. We are not out of the woods. We must continue to invest in critical research and development and to fund that research and development. We must finish the ongoing clinical trials. As Seth said, we must conclude agreements with industry to provide vaccine through the facility. And we must help countries prepare to receive vaccine. And finally, we must have realistic expectations about the efficacy of the vaccine and about the timing of its delivery. Vaccines are a critically important tool in the fight against COVID-19, but they are only part of the world's response, and we must support the other parts of that response as well. Today, I believe, will come to be seen as an important milestone, and perhaps what will come to be seen as a turning point in the fight against COVID-19. Thank you, and let me turn this back over to Dr. Tedros and to our colleagues at WHO.
Thank you so much, Richard. Thank you. I'm very, very grateful. And unprecedented the collaboration that we're actually having between us. I met some member states today, and they told me how proud they are actually of how we're partnering together, the Gavi, CEPI, WHO, Global Fund, UNITAID, FIND, the World Bank, the private sector, civil society, and others in the ACT Accelerator. And I was really proud to hear about it, and I told them actually the reason why this partnership of different health agencies is succeeding and why we're working very hard. And I know you know it, I don't want to go into details, but I wanted to just use this opportunity to appreciate, and tell you that how honored WHO is to partner with Gavi, CEPI, and the rest of our partners. Fadila, back to you.
Thank you, Dr. Tedros. Thank you so much, Dr. Hatchett. Now that we have heard from the three principals, I would like to open the floor to questions from journalists. I remind journalists that you need to raise your hand. Use the raise your hand icon in order to get in the queue to ask questions. We have several journalists online. I will start with Jenny Le Ravello from DEVEX. Jenny, can you hear me?
Hi, Fadela. Can you hear me?
Very well. Go ahead, please.
Okay, thank you so much for taking my question. Two quick questions. One is on the COVAX AMC facility. Mr. Seth Berkley talked about, they will begin to sign agreements with partners in the coming weeks. Last month, there was a collaboration between the Gates Foundation and SII about ensuring up to 100 million doses through the COVAX facility for LMICs. I just want to get an update in terms of how many more are you expecting in your current negotiations with vaccine partners, and from which vaccine manufacturers? And just very, very briefly, secondly, on the ACT Accelerator, I just want to get a sense, because the original investment case was, I think, around $31 billion, and there's now a discussion of a funding gap of $35 billion. Can I just get a clarification on the numbers, please? Thank you very much.
Thank you, Jenny. Dr. Berkley, do you want to take the first question?
Yes, absolutely. So, until we have signed agreements and finance for the upper middle income and high income countries, we cannot go ahead and close those deals. That's why this is such an important day. But for the AMC, of course, we already have an engagement going on that. And we have now signed for up to 850 million doses of vaccines as part of the AMC, and the rest of the manufacturers that Dr. Hatchett has talked about, both from the CEPI portfolio, vaccines from potentially the Gates portfolio if they make it, but also vaccines from the industry that have not yet collaborated on moving forward, are all eligible for this. So we will be looking during this next period to supplement those agreements that have already been made. And the last thing I want to say about this is that you heard the goal for us is to try to get to 2 billion doses. Of course, that's 2 billion doses of safe and efficacious vaccines. We know the failure rate for vaccines historically is quite high, with 4 out of 5, even in clinical trials, failing. So what this means is we are going to have to cut many more deals to get to the numbers we want. So that's where we are right now, but obviously we'll be transparent, and as more information comes out, we'll share it with you.
Thank you so much, Dr. Berkley. The question on ACT Accelerator, Bruce Aylward. Dr. Bruce Aylward, please.
Thank you very much, Jenny. So the first investment case for the ACT Accelerator that was released on the 26th of June gave the costs for the three what we call product pillars. So for the vaccine, therapeutics, and diagnostics work of the ACT Accelerator, which was indeed $31 billion at that time. But in that investment case, we highlighted there's a fourth part of the ACT Accelerator, which is vital to its success, and that's what we call the Health Systems Connector. And that part of the ACT Accelerator is the work to ensure that when these new products hit the countries, they can actually be utilized in the most efficient and effective way possible. So that part of the budget has been built in. So what you're seeing today in the new investment case, which will be fully revised and released later this week, will include the costs of what we call that Health Systems Connector. So the total cost for the three major product pillars plus the Health Systems Connector, the gap is $35 billion, as the Director General referred to. The urgent need is actually the $15 billion that we need right now to maintain the momentum. As Dr. Berkeley said, the COVAX facility is now open for business. We have new therapeutics, dexamethasone, we've been talking about, that we know reduces mortality. We've got new rapid antigen tests that show great promise. So there's great promise right now to get a step change in the global response to COVID-19, but it requires seizing this moment with the $15 billion in financing needed to fully exploit these opportunities.
Thank you, Dr. Aylward. We will take a question from the next journalist, Antonio Brotto. Can I just kindly ask journalists to limit your question to one, because we are very happy to have a large number of journalists, but limit your question to only one, please. Antonio from EFE, Spanish News Agency. Antonio, you have the floor.
Hola, buenas tardes. Gracias por concederme el turno. En la lista destaca sobre todo las ausencias de Estados Unidos, que creo que ya era un poco esperada, y también la de China. No sé si podrían comentar un poco si ha habido negociaciones con las autoridades chinas para que estén en COVAX y si tienen esperanza de que en el futuro pueda formar parte de esta red. Gracias.
Thank you, Antonio. Dr. Berkeley?
So the purpose of the COVAX facility is to try to work with every country in the world. And I can assure you that we have had conversations and will continue to have conversations with all countries. That relates to both whether they join the facility and the advantages of doing that, but also for countries that are producing vaccines, that if they have successful vaccines that come out, how we can make sure that those are made available to others in the world. So we will continue that dialogue.
Thank you, Dr. Berkeley. Now I would like to give the floor to Helen Branswell from STAT. Helen, but yeah, Bruce, do you want to add something? Yeah, no, okay. So Helen, you have the floor.
Thank you. My question was just asked, but I guess I will come up with another. It's hard to gauge how successful this has been. You know, 64% of the world's population are going to be in the program. Would you have expected more? I'm kind of puzzled that more are not in.
Thank you, Helen. Dr. Berkeley?
So thank you, Helen, for that answer. And remember, we announced today who has signed up with legally binding commitments. We have many other countries who have expressed interest to participate and who were, because of legal issues or parliamentary issues or other, delayed in making those. So we have 38 other countries that we expect, and maybe all of them won't show up, but I expect the numbers will grow and be significantly larger than they are today, but we'll see.
Thank you, Dr. Berkeley. I think Dr. Edward has something to add. Edward.
Yeah. Thank you, Fidela, and thanks for the question, Helen. I think we can look at this two ways, right? And we've got to look at this as a huge success. When we've got 64% of the world's population as a single entity working together, that's huge progress. And as Dr. Berkeley just mentioned, there are many others that are still interested to join. So what we've managed to do, or a lot of credit here, obviously, to Gavi, WHO, CEPI, who've worked together on this, is to build a coalition at a time when the world has been so worried about countries going bilaterally. We now have 64% of the world's population, and this is growing still. So this is huge progress, and I think provides a fantastic opportunity for us to achieve that goal of rapidly reducing the risk of severe disease in as many countries as possible, so we can get the world health systems safer, get the societies reopened, and then get, obviously, economies working again as rapidly as possible. This is huge progress.
Thank you, Dr. Aylward. The next question is from Nina Larsen, Agence France Presse. Nina, can you hear me?
Yes, hi Fidela, can you hear me?
Yes, very well. Go ahead, please.
Thank you. I'd like to ask a question on another topic. The CDC on Friday shifted its guidelines to say that small particles, such as those in aerosols, are the most common vector of COVID-19 and not the large droplets encountered at close range, as they stated previously. It seems to me that WHO has said, and I might be wrong, but that aerosols occur in certain settings, like in operating theaters, but have not given any conclusive information about whether the virus spreads through the air in other settings. So I was wondering if the WHO is considering shifting the guidelines on this as well, and if you agree aerosol spread is one of, if not the main vector of how of this virus, and how concerned we should be about sharing indoor spaces like the one you are in right now. Thank you.
Thank you, Nina. I think we will go to Dr. Mike Ryan to answer this question. Dr. Ryan?
Hi, thank you. Yes, we've seen the postings on the CDC website, and we're actually in touch with CDC to better understand the changes that have been made. There are parts of the website that appear to retain previous evidence and parts that appear to change. So we're just trying to check with our colleagues at CDC the exact nature of the change, if any, in their advice regarding this. Certainly, we haven't seen any new evidence, and our position on this remains the same. And we've always said, going back over months and months, about the potential for different kinds of routes of transmission, and particularly driven by the context, the proximity, the intensity, the duration, and the potential for different forms of transmission, including small particle transmission, particularly in poorly ventilated spaces, and the need for the appropriate precautions. Maria can speak to that advice, but we are obviously, CDC is a very learned and credible institution, so when CDC changes anything, we always look to them and ask and get the details, and we're currently following up, and will be doing so over the next 24 hours to understand the evidence that potentially drives any change in guidance. Maria?
Yes, so just only briefly to add, because Mike has answered really completely, just to say that we haven't changed our position. We do have a scientific brief that is out that describes all of the different modes of transmission that we are constantly looking at. As you know from the beginning, transmission and severity are two of the main features of any new pathogen that are really critical to better understand. And we are always looking at the literature. What really matters is how we protect people and how we ensure that transmission is reduced and suppressed, and countries are having great success in doing so. And so our guidance around physical distancing, the use of masks, avoiding enclosed, crowded settings, make sure you have good ventilation, hand hygiene, respiratory etiquette, manage your risk, really know what your potential exposure may be depending on where you live and where you work. And we're working with our member states to ensure that they take appropriate steps to reduce transmission.
Thank you. The next question is for Simon Ateba, Africa News Today. Simon, can you hear me?
Yes, I can hear you. Thank you.
Thank you. Go ahead, please.
Simon Ateba from Today News Africa in Washington, D.C. My question is to Dr. Berkeley of Gavi. You said that 64% of countries have cemented their commitment to the COVAX initiative with legally binding agreement. I would like to know how many of those countries are from Africa. Second, once a vaccine or successful vaccine are eventually approved, how do you intend to carry out vaccination in Africa? Will you start with some countries like South Africa, Egypt, Algeria, Ghana, and Nigeria, where there are most cases? Or will you do it at the same time? And if you allow me to quickly ask one last question on what Dr. Mike Ryan just said about the CDC. The CDC also said that coronavirus can spread further than 6 feet. Are you also looking at that area? Do you still stand by the recommendation that 6 feet is enough to prevent the spread of coronavirus? Thank you.
Thank you, Simon. I think we will go to Dr. Berkeley to answer the first question of Simon. Dr. Berkeley?
So thank you, Simon. There are 48 African countries that are included in the advanced market commitment. There are 8 self-financing countries that can join. Right now, 48 of those countries are part of the facility and will have access. The purpose of the original allocation framework is to try to provide vaccines equally to all participants, including developed and developing countries. And obviously, that has to be also joined to how fast vaccines get produced and in what allocation or what quantities they can be transported. But the idea would be initially to try to get to health workers around the world. And that is, up to 3% of a population, and then to add doses as vaccines get made. So the idea would be to try to make them available to all countries equally. After 20% of countries are covered, the idea would be that the allocation framework would shift slightly, and if there were differences in need, that would be taken into account. Last thing I'd say is that there is also a plan to put aside doses for humanitarian emergencies, and those, of course, could also be used in the circumstance where there were substantial outbreaks that needed additional doses. Over.
Thank you, Dr. Berkeley. I think Dr. Aylward has something to add.
Thank you for the question, Simon. And I just realized as you were asking the question, it's important for us to clarify one point. You said that 64% of countries had joined, and actually the proportion of countries and economies around the world that have joined the COVAX facility are actually much higher. And Helen, this goes back to the question that you asked, but remember, we now have 156 countries and economies working with the facility, and potentially another 38 that are in discussion, as Dr. Berkeley mentioned. And so that makes at least nearly 80% of the countries and economies around the world are already working with the COVAX facility, and that number may grow higher. So when you approach it from a proportion of the countries and economies around the world, it's a huge proportion. I just thought to be very clear that group represents nearly 70% of the world's population, but as a proportion of the number of countries and economies, it's even higher, which again is extremely important when it comes to that goal of equitable access. The more countries and economies we have working together, the better the opportunity to get these products rolled out in the right order to the right people at the right time.
Thank you, Dr. Aylward. I would like to remind journalists to unmute themselves when they want to ask a question. And now I would like to invite the next journalist, Kai Kupperschmidt from Science. Kai, can you hear me?
Yes, thanks for taking my question. and thanks, Bruce, for setting me up perfectly. The right people, the right order. So obviously, there are different ways of trying to distribute the vaccine in a fair way, in a way that has the maximum impact. And I just wonder whether you can speak a little bit to, I mean, you've gone for this two-phased approach, where in the first phase, it's proportional to the population. And in the second phase, countries are prioritized depending on threat and vulnerability. Can you just explain a little bit the modeling that goes into that? I mean, there are people who suggest that, you know, actually, for instance, vaccinating younger people who spread the virus more might be more efficient. So if you could just explain a little bit what went into that, and I assume it's not pure ethics and science, but also politics.
Thank you, Kai. I think I would like to ask Dr. Simao, Mariangela Simao, to take this question. Dr. Simao.
Thank you, Kai, for the question. There are several modeling, several indicators that will be taken into account. We haven't yet developed them fully. I'm talking about the second phase, right? Because it will depend a lot on the type of vaccine that will be approved. What type of population, the immunogenicity, who does it protect, and what's does it cover young people? Does it work well in older people, for example, right? So at the moment, we're working with two aspects. One is threat and vulnerability. And for these different models will be used that include, for example, mortality, includes rates of infection, it could include health system capacity, ICU coverage, for example. So it will depend a lot on the type of situation we have when we get to phase 2. Okay? At the moment, we're working with the uncertainties we have in relationship to the vaccine itself, the one that will prove to be both safe and efficacious.
Thank you, Dr. Simao. Now I would like to give the floor to Corinne Gretler from Bloomberg. Corinne, can you hear me? Corinne, please unmute yourself. Yeah.
Can you hear me?
Yeah, very well. You can ask your question. Go ahead, please.
Yes, sorry. I may have missed this earlier, but I was wondering if you still expect China will be involved with the COVAX program. Is it maybe one of the countries that asked for more time to commit?
Dr. Swaminathan, can you answer this question, please?
Yes, I can start, and maybe Dr. Berkeley would like to come in as well. So we've been engaged in discussions with China for the last several months because, as you know, they also have a very active vaccine development program, and several of their vaccine candidates are in advanced stages of clinical trials. So this is also of interest to us. So we're following those very closely. And we've had very constructive and open discussions with them, and they have always been reiterating their commitment to global access if some of their candidates actually prove to be successful in the clinical trials that are going on. So I think the conversations are going on. It's still open, and we're hopeful that more countries are going to join. But Dr. Berkeley might like to add something.
Dr. Berkeley, do you want to supplement, please?
So I think Soumya has done a good job answering that. I'd just say, you know, that they haven't signed up, but they have publicly expressed their interest in engaging with us, and so we will continue to have that discussion.
Thank you, Dr. Berkeley. I would like now to give the floor to Jamie Keaton from Associated Press. Jamie, can you hear me?
Yes, hi, thank you. I wanted to talk about the WHO's threshold for approving or giving its stamp of approval to a COVID-19 vaccine and the minimum efficacy rate. Would you possibly approve the use of a vaccine that's less than 50% effective, as it happened in some other types of vaccines? Thank you so much.
Thank you, Jamie. Dr. Swaminathan, please.
Thank you, Jamie. As you know, we put out the target product profiles for an ideal COVID vaccine. This was several months ago, and obviously these target product profiles are to help developers and funders to try to have some benchmarks for when they're developing the vaccine. We have two scenarios, a vaccine that's used mainly as a preventive and also a vaccine that could be used in outbreak settings to rapidly control outbreaks. So they have slightly different product profiles. But essentially, what it describes as a vaccine, ideally with 70% efficacy and above, but certainly 50% would be the point estimate that would, that's what we would classify as an effective vaccine. It's also important of how these endpoints are studied in clinical trials. Because as you know, around the point estimates, you have confidence intervals. And so it's also important that the confidence intervals are not too wide. In other words, if you do a clinical trial with small numbers of people, you could still prove a 50% efficacy, but you may have confidence intervals that go all the way down to 0, which means that there's a chance that the vaccine actually doesn't have any efficacy or has very poor efficacy. So we also specify the lower boundary of these confidence intervals, which is 30%. A vaccine that has less than 30% efficacy is probably not going to have a big public health impact, because you can see if you have a 30% or lower efficacy and you vaccinate a certain percentage of the population, it's going to be difficult to get to those levels of immunity. The FDA also has guidance on the criteria. We're very well aligned. The WHO guidance and the FDA guidance are very well aligned. And as clinical trials are proceeding phase 3, we're expecting to see some of these data. So it's also going to be important to have criteria for emergency use listing and then ultimately for pre-qualification. As you know, emergency use listing is a step on the way to pre-qualification or to full licensing, and is done in case, in pandemics like this, one might consider that. But again, there are minimum criteria also for safety. So one is on the efficacy side, but on the safety side, we would like to see several months of follow-up to assess the adverse reactions, particularly since we have so many platforms that are currently being tried, which are first-time platforms, like the RNA and the DNA vaccines, and even the non-replicating viral vectors have not been used at scale. And therefore, safety considerations are important, because here's a vaccine we're going to use on billions of people. And so the risk-benefit profile has to be very, very strong. Kate, you want to add something?
Yeah, I think what I'd just like to add to that great explanation about sort of how we consider the evidence from trials. It's really important to remember that there's also a policy process. And although vaccines, or frankly any product, may achieve authorization, licensure, how that vaccine is actually used, in which groups, and certainly will be taken into consideration the magnitude of the efficacy and in which groups that efficacy was demonstrated. So at WHO, we do have the policy process in motion, considering the evidence right now, and we'll continue to watch very carefully as that evidence accrues. Thank you.
Thank you, Dr. O'Brien. I would like now to invite Leroy D'Souza from Mint, India, for the next question. Leroy, do you hear me?
Hi, I can hear you.
Yeah, please go ahead.
Yeah. So the thing is, my question is specifically with regards to India. Now, India is part of the Gavi AMC eligible countries, but has there been any sort of discussions about payments or the total number of doses that are needed? And also, among the 4 candidate vaccines that are there, that are part of the COVAX facility, apart from the serum, Oxford serum vaccine that is there, are there any others that are being, what are the others that are there? And are any talks going on with Indian manufacturers?
Thank you, Leroy. Dr. Berkeley, do you want to take this question, please?
Sure. So thanks for the question. India has a very special role to play. It has a whole group of indigenous vaccines that they're working on. There's a powerful science engine going on there. And they also have massive manufacturing capability. And so we have had a series of conversations on the R&D side with all of the manufacturers, and also with the manufacturers on the ability to scale up and produce. Of course, India is Gavi's largest eligible country, and so they are part of the AMC, but also given the size of India's population, we have always had a special strategic relationship with India. And so we have had a series of conversations, and we'll continue to work on those conversations on how we would be able to provide vaccines, which we would purchase, which India would purchase, and how those would be scaled up appropriately. I don't know if Soumya wants to add anything to this, given her engagement also in this work.
So, yes, thank you, Seth. I just wanted to add that India is also obviously a very good place to do clinical trials for multiple vaccines because of the population that is exposed, but also because of the capacity that exists and the institutions that are capable of doing randomized clinical trials. So we are discussing with the companies as well as with the ICMR and the Ministry of Health on clinical trials for multiple candidate vaccines, both those made in India as well as those that are available outside. And so we hope that there'll be a lot of activity in the coming months, both on the R&D side. There are several candidate vaccines that are advancing, at least 7 or 8 of them. And so we hope to see results coming from those studies. The first few are now in phase 1, phase 2, and in the next couple of months, I think we should start seeing the immunogenicity and the safety data coming in. They're also in conversation with CEPI for partnerships on R&D.
Thank you, Dr. Swaminathan. Dr. Richard Hatchett, do you want to add something on the vaccine issue? Yeah?
Yeah, no, just to say that the Indian manufacturers, as Seth and Soumya have said, are very much, participating in the global response. They are supporting the manufacturing of vaccines by international companies as well as developing their own. They have a terrifically exciting and robust biotechnology community. And we have been deeply engaged in discussions with them and look forward to collaborating.
Thank you, Dr. Hatchett. Thank you so much. Now I would like to give the floor to Sarah Wheaton from Politico. Sarah, can you hear me?
Yes, thank you for taking my question. The goal, as I understand, for COVAX is to secure 2 billion doses, but given that some vaccines would need 2 doses and some would need 1, just wondering why that is the unit as opposed to just saying we want to, say, vaccinate 2 billion people. And when we talk about phase 1 and phase 2, and that phase 1 would give each country enough for 20%, does that mean 20% would get a full course, or 20% of people would get 1 dose, even if it's a 2-dose vaccine? Thank you.
Thank you, Sarah, for this question. I would like to invite Dr. Kate O'Brien to respond.
I think it's important to recognize that the 2 billion dose number is predicated on the idea that it would be a 2-dose regimen. We don't know yet which vaccines are going to reach success and licensure, so that's the direction we're planning for. But that's really only through 2021. The aspiration, of course, is to go well beyond 20% immunization and to extend that to all people who would benefit from protection through vaccines. I think the other important thing to say is that as we envision the scope and breadth of what needs to be done, is the delivery at scale enterprise to actually get this number of doses in this time frame to people across all countries is an enormous enterprise, and countries are preparing for actually deploying vaccine in all the different ways that that preparation needs to happen on the cold chain, on data monitoring, on readiness of healthcare workers to actually deploy that vaccine. So we have to really remember that what we're talking about today is really the first phase of what needs to happen, and the aspiration is to assure that we are able to secure more vaccine for all people in all countries who need it eventually.
Thank you, Dr. O'Brien. I would like now to give the floor to Imogen Fulks from the BBC. Imogen, can you hear me?
Yes, I can.
Yeah, please go ahead.
Could I just come back to the drivers of infection? Because I wasn't quite sure that Nina's question from AFP got answered as clearly as we might like. Because I think the question was that CDC is suggesting that aerosol is the main driver of transmission. And I know that you've never ruled anything out, but from a long time you were saying that droplets were the primary driver of transmission. So, I mean, you say your position hasn't changed. Do you still think droplets are the primary driver of transmission then?
Thank you, Imogen. Dr. Ryan?
Yeah, no, I think you may find that the advice that's been posted by CDC is actually draft advice that has been, I think, taken down at the moment as we speak, because I think it was maybe posted inadvertently. So I believe from that perspective, I think we need to see what the final advice of CDC is. But that doesn't mean we can't talk about this very important question, which is the spread of this disease. Unquestionably, the disease can spread by many different routes, and we've seen that. We believe, based on the epidemiologic parameters, that the primary mode of transmission is through the respiratory or through the direct person-to-person route. Depending on the size of aerosols, we believe that symptomatic individuals infect the majority of people at close range through the direct contamination with droplets. And then there is always the risk, and is the risk of further transmission at longer distances. And Simon Ateba asked earlier about this 6 feet versus 3 feet. There is no question that distance is a factor. There is no question that duration is a factor. There's no question that ventilation is a factor. All of these things. The risks decline exponentially as you move further away from another individual. The risks decline depending on ventilation. The risks increase depending on the density of people. And that's why it's so difficult to say with absolute. If Simon asked earlier, is 6 feet better than 3 feet? Of course it is. Is 9 feet better than 6 feet? Of course it is. The issue here is to find out what is the best balance of measures that manage most of the risk and then allow us to be able to exist within our society. So it's the same thing when we talk about the period of time for contact tracing. We say 14 days. That does not mean that 100% of people develop disease in 14 days. What it means is the vast majority of people will develop disease within 14 days. We could follow people up for 30 days or 50 days. The question is the balance of the resources required versus the benefit we gain in terms of disease control. All of these parameters need to be put together. So we still, based on the evidence, believe that there is a wide range of transmission modes. We believe the disease is predominantly or primarily spread through droplet spread and through larger droplet nuclei, but we have always said that smaller droplet nuclei can spread this disease, and that is very context-driven. People crowded into a small space without adequate ventilation, where they're there for a long duration of time. In that situation, aerosol-based transmission can occur, and it has been demonstrated to occur. The question is what's driving the day-to-day transmission of the disease. And we need to stop all sorts of transmission. We need to look at all types of transmission. That's why we talk about avoiding crowded spaces. That's why we talk about ventilation. That's why we talk about the duration of time you spend in those spaces. So the advice in that sense does not change. It's about knowing the risks managing the frequency, intensity and duration of time you spend in the company of other individuals in crowded spaces, and when you can't physically distance, when you can't fully manage that, to be aware of those risks and to ensure that you always have a mask with you so you can wear that mask in situations where you can't distance yourself appropriately from others, and to always remember to maintain good hand hygiene. So these are really important issues, and I think we have to level with people. There are no absolute risks. There's no situation where this is risky and this is not. And where this is bad and this is good. It's about finding the best balance of behaviour, the best balance of risk that allows us to go back to school. For example, I'm sorry to go on about this, but many countries have brought children back to school successfully. It's been very, very tough. It's not been zero risk. The risks of transmission still occur. We're balancing those risks to benefit our children's education, to minimise their risk of exposure or bringing the disease home. But it's not zero risk. And great credit goes to those schools and local school authorities and governments who've managed to do that successfully. So I do think as we move forward in this pandemic, we've got to become able to accept that there are very few absolutes in this response. And we've got to be able to be smart and make smart decisions, and smart decisions are made based on understanding risk, minimising risk, and then being aware of the residual risk, and as best we can to avoid that. Maria, I think you may have...
Thank you, Dr. Ryan. We are going to move now to South Africa, to Sophie Mokoena. Sophie, can you hear me?
Yes, I can hear you loud and clear. My question is around the issue of making the drug or the vaccine or whatever medicine available to ordinary people. Activists or ordinary people around the world are asking for a moratorium on all COVID-related patents with the intention to ensure that you don't have a situation where companies and individuals are profiting while people don't have access to such important vaccine or medicine or anything that can help them, and also to ensure that you classify health as a public good. What is your reaction as a panel?
Thank you, Sophie, for this interesting question. Dr. Simao?
Let me start, and maybe colleagues can complement. I think we are very clear, WHO is very clear when we are talking about COVID technologies that work to save lives and to prevent infections as global public goods. Right? And it's in this framework that WHO has been working with partners, including Gavi and CEP in the vaccines field, to ensure that there is equitable access to these technologies. We understand that for specific products like vaccines, for this acute period, that intellectual property barriers are not necessarily the most important barrier. We expect that next year the most important barriers is the capacity to scale up production and to make these products available. And we know that some of these manufacturers will be selling these products at what we call a cost plus, which is not intending to have profit. Right? On the other hand, we do have products, for example, for treatment. When you have like a product like dexamethasone, which has helped to decrease, it has proved to decrease mortality in severe patients, which is not patent protected, it's available across the world. It's a very old drug. But we have expectations that we may have a new therapy, and this could be like a biotherapeutic, which is, as we speak, the current ones in the market for other diseases are very costly and are patent protected, and they are hard to be scaled up and to be copied. So we do expect that for medicines, even if these new biotherapeutics prove to be safe and efficacious against COVID, that we may have IP as a barrier. And this is why we are also working together with UNITAID and the Wellcome Trust to address this beforehand. And this is expected in case one of these new therapies become available in the market, right? For example, you have the case of monoclonal antibodies who are already complex molecules, and they are already used for other indications, and they are very expensive. So this is an issue that will have to be tackled, and we are tackling it together with partners. Thank you.
I don't know if Dr. Berkeley or Dr. Hackett would like to respond also.
Yeah, I'll just add one word to that. And if you look at biologics, the main issue is not patents. The main issue is know-how. And that's because these are, basically living organisms or components of living organisms, and therefore the whole process is the critical piece. So, in my experience of 30 to 40 years working around vaccines, I can only think of a handful of cases where a patent was a major issue. And that know-how then becomes very important on how we form the partnerships to have companies be able to transfer technology to other companies. And that's a lot of what we're trying to do here, is to make that available. I'm sure Richard will say something about that. And if you try to re-engineer the vaccine production without the know-how, it takes years and years and years. If you have the know-how, it's still difficult, but it can be done in a reasonable period of time. So that's really what we're trying to work on by forming these partnerships with industry.
Yes, I would
Dr. Hatchett?
Just add, yeah, sure, thank you. No, I think Mariangela and Seth have put it well. At least with respect to vaccines, the IP barriers are not the most important barriers to equitable access. Mariangela mentioned the capacity to scale. I would also say the capacity to deliver is critically important. I think it is critically important to maintain a balance. If you look at the global innovation effort that has been driven in the response to the pandemic under the current intellectual property regimes, without taking away intellectual property protections, you see well over 200 vaccine development efforts. You see a number of companies that have worked with partners globally to provide the technology transfer, sometimes with public funding, but often without. And you see tremendous investment. You see tremendous progress in developing vaccines. And so you have to balance any effort to right what you think may be a wrong with what you might potentially give up. And if you inhibited innovation by taking away intellectual property protections, even though they're not really, where vaccines are concerned, the major barrier, you could have unintended negative consequences. I think what we're seeing through the participation in COVAX and the willingness of countries to come together in the face of a global threat is a potential pathway which, without disrupting intellectual property regimes, can provide for the kind of global simultaneous access that we all want to see.
Thank you, Dr. Hatchett. Now I would like to give the floor again to Dr. Sibao for
I think it's important, thank you very much, and thank you, Seth and Richard. It's important to complement the information as well, because WHO has, in late May, launched a COVID technologies access pool, right? Which is, because what we have seen during this pandemic is also an unprecedented move from some manufacturers on the sense of, for example, open licensing their patents, or for sharing, unprecedented sharing of information, scientific information on research and development that we had not seen before. So WHO, at the request of the government of Costa Rica, and together with 40 countries, has launched what we call the CTAP, a COVID Technology Access Pool. And that it's a voluntary pooling, and it's working with initiatives like the Medicines Patent Pool, and with the WHO Global Observatory on Research and Development, in the sense that we would like to see more of the sharing of not only of the patents through voluntary mechanisms, but also of the scientific information that's being developed throughout this pandemic. Thank you.
Thank you, Dr. Simao. Dr. Kate O'Brien would like to add something.
I'd just like to add on the second part of your question about global public goods. I think it's really important. I think what's been addressed is the patent issue, the IP issues. But SAGE has, and WHO has now released a values framework for how the policy, which will consider these products, is going to actually look at the distribution of values that will help allocate vaccines and make recommendations for populations within countries. And given that these are global public goods, it's so important for this to be a transparent process and a clear framework for how we're thinking about who gets vaccine first and who gets vaccine second, notwithstanding that the development of the vaccines is really not largely limited by these IP issues or patent issues. So I think understanding each of these elements that will lead to the actual access to vaccines in an equitable and fair way that makes sense and is driven by science is really important. Thank you.
Thank you, Dr. O'Brien. We have still a lot of questions from our journalists and not much time, but I would like to give the floor to a journalist from Norway. I hope I pronounce well your name. It's Oda Skaitne from VG Norway. Oda, can you hear me?
Yes, I can hear you.
Thank you. Go ahead, please.
Neither Russia, China, or the US is on the now published list of countries that have committed to COVAX. Are you disappointed in them? And what does it mean for the success of COVAX that these countries won't participate?
Thank you, Oda. I would like to invite Dr. Berkeley to take this question. Dr. Berkeley?
I think it's important for us to continue to be open to vaccine producers, research, and countries around the world to have them engaged. You know, we will continue that conversation. As you've already heard articulately stated by Bruce, that, you know, right now, you know, more than 70% of the world's countries are coming together. We'll see what the final number is, but it may get up to the 80s or 90%. And so we will work with those countries and move forward on it. So I think that's the reality of you know, of where we are right now. And you know, at the end, we want to make sure that we get to the point where everybody has access to vaccines. And of course, you know, a number of countries have decided to provide vaccines by, you know, having their own large portfolios, and we gain from that as well because they invest heavily in R&D, and that helps us drive forward the overall agenda.
Thank you, Dr. Berkeley. I think we will take the last question from John Cohen. John, can you hear me? John?
Yes, can you hear me?
Yeah, very well. Go ahead, please.
Thank you so much for taking my call. I'm confused about a very fundamental question, and it has to do with at-risk manufacturing versus the advanced purchase commitments. I understand that CEPI is investing in 9 vaccines for research and development, but I don't understand how the COVAX facility is investing in at-risk manufacturing, or if it is. And I have one other more complicated question about monoclonal antibodies. If they work as preventives, and I realize there are access issues and supply issues and cost issues, but doesn't that somehow impact this whole framework and scheme?
Thank you, John. I would like to invite Dr. Seth Berkeley to take the first question.
Thanks, John, and I can give you a quick answer. And if you want to have more discussions, we could continue to the discussions. But the idea, of course, is CEPI is investing in a number of platforms and technologies, and they've been investing in multiple different components of that. For the COVAX facility, we are not primarily an R&D organization. But what we can do is work to make sure that technology transfers occur, that manufacturers scale up by putting incentives in place for them to do that, and by paying the reservation fees for their vaccines to move forward. So those are some of the levers that we can use as part of the effort that we have. I don't know if Richard wants to add something to that.
Yeah, please go ahead, Dr. Hatchett, if you have something to add.
Sure. No, just that CEPI has made a number of investments early on to support the at-risk manufacturing, and that essentially are making investments to accelerate manufacturing before we have the clinical trials. Just to be clear with everybody, what we're talking about, and we've worked very closely with Gavi to think about how these manufacturing costs get allocated and who pays for them. I think that we have always viewed the manufacturing as at early a time as possible as part of the speed premium. It does increase the financial risk entailed, but if one wants to have large quantities of vaccine available when the clinical trials demonstrate safety and efficacy, you have to make those investments. Whether they're made on the development side or made through an advanced purchase agreement, either pathway can be used to facilitate that. In terms of John, your question about monoclonals, we are all watching the monoclonal story. The therapeutics accelerator under the ACT accelerator is making the principal investments in monoclonals at this point, not COVAX. But I think going forward, as we move through this pandemic, but certainly, into the next interepidemic period, and as we think about preparedness for pandemics more broadly, I think there's going to be a spectrum of technologies that have potential applications and benefits. And I've even started talking about vaccine-like technologies, and monoclonals in their prophylactic capacity, kind of fall into that category. They also have potential therapeutic applications, and it's a critically important technology for us to figure out how to be ready to provide globally. And hopefully further technological advances will bring those cost of goods down and make it much easier to contemplate distributing those globally. Thanks.
Thank you. Dr. Swaminathan?
Just to supplement what Richard said on the monoclonals, we're looking forward to several trials that are going on now. We know of several developers of monoclonal antibodies. And John, as you very well know, these could prove to be an effective solution both for prevention as well as for treatment of early or moderate disease and late-stage disease. All of these, of course, we need to wait for the results of the trials. It cannot be a substitute for vaccines because monoclonal antibodies have a limited duration of action and would need to be repeated many times. Hopefully vaccines will offer a much longer duration of protection. But as Richard said, I think we have to look at a package of interventions in order to bring the pandemic to a control, both on the prevention side as well as on the therapeutic side, and very importantly on the diagnostics side as well. So it's going to be one more element or measure in the armamentarium that we need. And finally, I think monoclonal antibodies have a future beyond, obviously, this infection. There are many other infectious diseases, and they're non-communicable diseases like cancer, for which monoclonal antibodies are already being used, and there are going to be growing indications, I think, in the future. So this is a good time to invest in capacity for manufacture of monoclonal antibodies in the developing world, so that in the future we can use this technology for multiple infectious diseases.
Thank you, Dr. Swaminathan. Dr. Edward has something to add.
Yeah, I'm sorry, but John, you touched such an important point, and I'm going to sound like, quote the Director General here when he keeps saying you have to do it all. And when the ACT Accelerator was set up, it was not about finding a vaccine or finding a diagnostic or finding a therapeutic or the other measures. It was about doing all of it, because exactly like Dr. Swaminathan said, we need the whole package. We need the integrated package to manage this disease, to get our health system safe, keep the populations healthy, get our societies reopened, and get the economies reopened. So it's going to be that mix of vaccines, therapeutics, but then Dr. Swaminathan, in her last point, she made the point of diagnostics, right? And Mike keeps hammering this again and again and again. If we can rapidly diagnose people, they know their status, they know whether they're infected, and they can then properly isolate contacts, properly high-risk contacts identified, we can do so much more to control this disease today. So if you look at the plan for the ACT Accelerator in our very first phase, a big emphasis was on the scale up of the the diagnostics, and then dexamethasone and the other interventions that are coming down the pipeline, because there's a lot we can do today to be reducing morbidity and mortality of this disease much more.
Thank you, Dr. Elward. I think we will be closing this press conference. Before I hand over to Dr. Tedros, I would like to ask Dr. Berkeley and Dr. Hatchett if they have anything they want to add. Dr. Berkeley, Dr. Hatchett?
I want to thank everybody for the excellent questions, and I want to remind people that we are moving quickly. It's an unprecedented new set of collaborations, and people are working together very hard. So there will be adjustments and changes. For example, one thing that I didn't comment on because my colleagues asked was, why 2 billion doses? Well, the answer is when we originally began to think about this, we said, what's possible? What do we think is possible to be produced in 2021? We have no idea, of course, which vaccines will succeed, what the scale up's going to look like, what the yield's going to look like. So we began to plan on what we thought was possible. As we get more information, those plans will change and we will have to adapt. So that's going to be the challenge in front of us, is trying to turn this into equitable access for all under the best science conditions, but also understanding that we will not have all the answers and now or even in the near future. But thank you everybody for listening, and we look forward to continuing the discussion with all of you.
Thank you, Dr. Berkeley. Dr. Hatchett? Please, you have the floor.
Thank you. Just to build slightly on what Seth has said, I think we have only gotten this far because the entire world has been galvanized by the threats that we face. To get this far, we have engaged in a very productive and ongoing set of conversations and collaborations with our industry partners, with our non-governmental partners, with WHO, and with the countries that are involved in it, and many of whom have just made commitments to join the COVAX facility, which is a huge vote of confidence, but also a huge vote for proceeding with this response as a collaborative, collective effort. I too want to thank all of you for joining. I've spoken obviously with many of you in the past. We are here. We do want to talk about what we're doing. We welcome your questions, and we will try to be as transparent as we possibly can, recognizing that we are continuing to evolve and respond to changing circumstances in a very dynamic time. Thank you.
Thank you, Dr. Hatchett. Now I would like to give the floor to Dr. Mike Ryan, who wants to add something.
I know the DG will speak to this again, but I think as it is the 75th anniversary of the founding of the United Nations, and as a proud staff member of WHO and someone proud to serve within the United Nations, we just want to say to our colleagues around the world, all of you out there who get up every day to serve those who are least and to preserve the peace and to fight for human rights, we thank you, and we hope we can continue to serve. We're certainly proud to be WHO, we're proud to be UN, and Richard and Seth are proud to be COVAX now, so we have a new flag to fly. Dag Hammarskjöld said, one of the great leaders of the United Nations, said the UN was not created to take the world into paradise. It was created to save the world from hell. And I think we should reflect upon the role we need to play now together as we face yet another global crisis.
Thank you, Dr. Ryan. DG?
Yeah, thank you. So, how about starting by saying happy birthday to the UN, 75th birthday. Coming to the COVAX, 64% of countries being part of the COVAX is unprecedented. So that's one. And many more are interested to join, so we will continue the dialogue, because with more countries joining, will really have a very positive, impact for its success. And then one thing which is very clear is, and we have been saying it, the partnership between countries is not because some countries are going to give charity to others. It's not a charity. It's because cooperation, especially on vaccines and opening up the economy faster, is in the interest of everybody. So I have said it in my speech, for the world to recover faster, then it has to recover together. And that's why. And it's in the interest of each and every country in the world. And that's what we're trying to say. So thank you so much to all journalists who have joined today, and also to our colleagues, Seth and Richard, and to other colleagues who haven't joined us today, who are working or who have been working on COVAX and on ACT Accelerator in general for the last several months. So thank you so much, and see you in our next presser. Thank you.
Thank you, Dr. Tedros. I now close this briefing, and I will remind you that you will receive the audio file and the DG opening remarks. The full transcript will be available later on. And please check out the WHO Gavi and CEPI websites for more information on our today's theme. As always, I apologize to those who could not get their questions answered, and do not hesitate to contact us for any follow-up question. Thank you so much. Au revoir.